I was initially attracted to epidemiology because I have an interest in prevention rather than just cure. And I started out training in medicine, and I really found that, my experience was by the time people had gotten to the hospital, it was often too late for a lot of them. So I had an interest in prevention, but I also had an interest in a sense, a sort of natural curiosity and an interest in research. So I used to get things thrown at me at medical school for asking too many questions. I was that level of curiosity. And they do say that, in a way, medicine only became effective when doctors learned to count. And I think that is very true. By about my third year, I was very, very frustrated with what seemed to me to be a lack of links between the evidence and what people were doing. And then I actually saw a talk by an epidemiologist called Judith Lumley, and I thought, that's it, that's exactly what I want to do. So from about third year onwards in my training, I was really hooked on epidemiology. People actively trying to discourage me from going into public health and epidemiology. I was told, well, you got really good marks, and so you really should be a physician or something like that. And I think what has changed quite substantially since then is that a number of those people have come up to me and said, well, actually, I can really see now why epidemiology is important and why public health is important. And I think it's now become quite mainstream to really work in epidemiology or to understand epidemiology as part of clinical practice. And for certain people doing a Master of Public Health, it's seen as being a well-rounded clinician. From my point of view, one of the most important developments that's happened over the last 20 years, which really is how much my career spans at the moment, has really been the use of very large-scale data to look at major questions of importance. And that includes routine pooling of clinical trials and large-scale clinical trials, large-scale cohort studies, and data linkage. So it's really about being able to use big data to address real-world questions. And it's also been incorporated in concepts such as the systematic reviews and quantitative meta-analyses of data. And one of the reasons why that's important is that when you use multiple small studies or have small studies, their results tend to waver around a sort of general mean, and they often also look like results are flip-flopping between the two. So you often hear media people going, well, one day the boffins are telling us this and one day the boffins are telling us that. And you really only get stable and reliable results when you use really big data and you summarise them carefully. Well, I think that I've had the kind of challenges that everybody has to deal with over time, and those are things like work-life balance. Actually being female in some circumstances has been quite difficult. But I would say that in terms of a central challenge that I've had throughout my career, it's really been about keeping the direction going where I want to go and balancing opportunism where there are grants, where there's funding to do research, and actually keeping the direction of where I really, really want to go. I'd also say that in terms of working on large-scale data, which is what I do a lot of, there's a real challenge, which is the investment in collecting the data is very, very large. You can spend many years just really working on the infrastructure for your research, and you have to make sure that you're actually keeping your career and other things on track, and you're actually getting research outputs while you're doing that. I suppose the first thing I would say is that evidence has to be part of the solution. It may be a bigger or a smaller part of the solution depending on the other things that are in play, but it really should be part of the solution. But the other thing I would say is that the thing, in my mind, what I've seen that has been most powerful in terms of getting evidence into policy is actually having systems within government that actually mandate the inclusion of evidence at different points. So I think that drug regulation is an area which is really obvious in that a lot of the drug regulation systems we have really grew out of the thalidomide incident in the 60s and really the visible and tragic circumstances around that. So there was an idea that, well, it's obviously imperative that we have evidence in our drug regulation and in our drug regulation policy. But I would argue that there are as many disasters going on in areas of social policy, in areas of agriculture, in all over the place that have outcomes that are as tragic but in some ways less visible and there's possibly greater difficulties in applying evidence systematically to them. So I would say that we need to actually not just be thinking about getting evidence into policy, but thinking about getting systems in place within policy that integrate evidence along the way. We probably shouldn't be overlooking just the basics about places that don't have enough water, enough clean water, enough food, that are torn by conflict, and I think we shouldn't lose sight of those global priorities. I think another global priority that is absolutely imperative is smoking. So we estimate that there were around 100 million deaths from smoking in the 20th century. We estimate that if things continue the way they're going, there will be 1 billion deaths from smoking. So although it sounds like it's old hat and we already know it, you could look at those billion deaths and say, in fact, they are less excusable than those 100 million deaths in the 20th century, because some of those 100 million deaths occurred when we didn't know what smoking did. If I'm talking locally, people often talk about the challenge of the ageing population, and that's a two-edged sword, because in a sense it's a marker of our success. So although we talk about the ageing population as being a problem, it's really more of a problem around cost and resources than it is around and maintaining quality of life than it is around a health challenge. Clearly the obesity epidemic is a really big problem, and I think there are problems with disadvantage. But I would say that if you take all those problems put together, one of the main things we have to look at is balancing maintaining appropriate prevention and population health with the increasing demand for technology and the resources and including new drugs and new technologies, and how we balance those two things. Because in a sense, a lot of our great successes, if you look at that huge drop in mortality we've had in Australia, it's largely driven by reductions in smoking, better control of blood pressure and blood lipids, and changes in diet, those sorts of things. So if we want to keep improving those things, we do need to pay attention and resource the public health elements of it, but we also need to balance that with demand for health technologies.